This meeting is being recorded.
Hello, everyone. This is Dr. Siddharth Tambar. Welcome to our webinar today. As we get started, someone who's currently watching live, could please just let me know if you can hear me loud and clear, and if you can also see my screen, that would be wonderful. Okay, great. So today we are talking about regenerative medicine treatments. What you'll get from this webinar is the following. You're going to learn about the different types of non-surgical treatments that are available for arthritis, tendonitis, injuries, back pain, and musculoskeletal injuries. You'll learn about what is legitimate in the field of regenerative medicine, how to choose the right provider, what procedures you should consider, and where regenerative medicine treatments fit in some of our other conditions as well. So, and again, after we're done today, you can learn more. You can contact us via the website, chicagoarthritis.com, and we're available here for answering questions or anything else that, that you may need assistance with. A bit about who I am. My name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology and regenerative medicine, specialist in image-guided musculoskeletal injections. In practice since 2008, involved in regenerative medicine since 2008, and within the Regenix Network, which is the largest organization of affiliated physicians working regenerative medicine since 2012. My own personal journey into regenerative medicine starts with really my own shoulder. I played fairly high-level tennis when I was a teenager and never really had any shoulder problems. In my medical training, which is about 15 years after I'd stopped playing at a competitive level tennis, found that I had a little bit of a rotator cuff injury and started to learn more about those types of injuries, tendons and ligaments, and realizing that a lot of what we were offering patients was not really adequate. In learning more about ultrasound and how to use it in musculoskeletal conditions, I started to meet colleagues. This is back in 2007, 2008, who were utilizing things like Prolotherapy and PRP at that time for their patients with arthritis and tendon problems. And that got me involved as I started my own practice to find solutions for my patients as well, and eventually sort of progressively involved in other aspects of those treatments, eventually bringing in bone marrow stem cells as well. So traditional care, we know there's a lot of problems with that, includes issues like pain medications have issues, the traditional injections like steroids and nerve blocks can help with pain, but are not really great. They have a lot of side effects. Most of these options will mask the pain, and now we're just waiting for eventual surgery. And, you know, surgery has its own risks. And so there's a huge gap in terms of care, in terms of how we can address people who don't need surgery, and yet people who are just, instead of just waiting to progress, things that we can do to help them out. By the way, as I am speaking, please leave any questions that you have in the chat, and I will certainly pause from time to time to answer those as well. Okay, great. So in searching for better options, we want options that are low risk and avoid serious side effects. They should address the actual source of the problem, which is instability. And they should also treat inflammation and metabolic issues, because that is what drives these kind of joint problems. We want to improve the actual cause of the problem, and we want to give longer term improvement if possible. So as a rheumatologist, how do I think of regenerative medicine, right? So there's quite a few different types of arthritic conditions. There are conditions where it's a total body problem, systemic problem, metabolic, inflammatory problem. And then there are degenerative problems, tendonitis or arthritis problems, where it's progressive wear and tear that's leading to issues. The keys in all of this is that you should be treating the actual cause of the problem. And those causes are instability and inflammation. And if you have an issue that is instability in a joint, if you failed conservative options like strengthening exercises, then you should consider regenerative medicine treatment. If you have an inflammation problem, is it inflammation just in one joint where we can treat it locally? Or is it inflammation throughout the whole body? If it's throughout the whole body, then you want to use an appropriate treatment for the whole body. So regenerative medicine is the process where we utilize your body's own cells to treat arthritis, tendonitis, injuries, and back pain. We're utilizing your body's normal healing process, which we'll talk more about. The normal process is, and you can take something as small as like a cut on your finger. You have an injury. You have cells that enter the area to begin with platelets. Those platelets first stop the bleeding. They then release growth factors, which then stimulate your local stem cells. They then lead to short-term inflammation that brings more cells and then eventually a cellular repair process. So tissues that have good blood flow, like the skin, this works very well. For tissues that have poor blood flow, that do not heal well, that they tend not to heal well on their own. That includes tendon, cartilage, ligaments, discs, labrum, and meniscus. These tissues are very hardy to begin with. They can take on a lot of stress, but once they've been repetitively injured or too severely injured, they tend not to heal very well on their own. So regenerative medicine is the process where we take your own body cells, platelets and bone marrow stem cells, and then inject those into tissue that's been damaged so that we can get that normal reparative process. So why regenerative medicine? It treats the source of the problem. It treats instability by treating the ligaments and tendons around a joint. And it treats inflammation by treating the joint itself or a tendon that's inflamed. These treatments are safer than surgery. For those of us involved in this work, we feel that strong, and this is effective for most musculoskeletal conditions, not 100%, but most. And that 80% of what is going for traditional orthopedic surgery will or should be managed by regenerative medicine even right now. In the same way that 99% of what used to be handled by open cardiac surgery is now handled by needle-based procedures that cardiologists do without big open cardiac surgeries. So again, how does regenerative medicine work? You're optimizing tissue that's been damaged. You get the cells to start functioning better. You can strengthen, stabilize, and supporting tissues around the joint. You can reduce chronic inflammation, and you can also even improve muscle and nerves that have been chronically weakened or damaged as well. It's a busy slide, but what makes regenerative medicine expert? I think it's important for folks to realize, because when it comes to deciding what's right for your own care, these are the things you should be looking for in regen med. Number one, your physician should be a musculoskeletal expert, and that means that's what they're focused on, right? They're not sort of dabbling in a few different things. They're focused on joints. Number two, they should be non-surgical expert. Our surgical colleagues are very good at the surgery aspect. The reality is, in the non-surgical aspect, which includes a lot of image guidance for procedures, they don't get that sort of training traditionally. So with image guidance, it means that for every injection that they're doing, they're utilizing X-ray and or ultrasound, And the reason why is because when you're injecting cells, you have to be very precise in terms of where you're placing them. You cannot be close. You have to be exactly in the right spot. Your physician should understand how to utilize inflammation. Your normal healing process utilizes inflammation. Regenerative medicine utilizes inflammation short-term. I see a lot of colleagues where when a person first comes in, they're offering steroid injections. And the problem is they're not understanding that inflammation short-term is okay, chronically is a problem. But because they're using steroids up front, they're sort of short-circuiting your body's normal ability to heal after an injury. And they can actually make your regen med process or success worse if you've had recent steroid injections, because it is actually damaging the cells that you need for healing. They should understand how to use the different types of biologic treatments. There's a few different ones that are legally available in this country. They should understand when it's appropriate for one or the other. They should be able to give you a nuanced regen med treatment plan, not just the same thing they're giving to everyone. I'll talk a little bit more about that in a bit. They should understand prolotherapy and instability. Again, we'll talk about that in a moment. That's very key, though. They should be very transparent about your results and candidacy. It shouldn't be that they're telling you, hey, not sure if this is going to help. If they're an expert in this field, they should know what's the average improvement to expect, and they should understand what is your candidacy, like realistically, not just a gut instinct sense of are you a candidate or not. They should really have an understanding. Are you going to get on average 65%, 80% improvement? Like they should have an understanding of that. They should follow your results long term. This is not the classic sort of pain clinic model where you come in, you get an injection, then you never see the doctor again. They should be following your results long term. And then they should guide you through the process. They should be knowledgeable enough where you trust them to go for questions and problems. Some brief kind of quick FAQs that people have about these treatments. Is this legal? Answer is yes. There are some very strict guidelines from the FDA, including when you're treating, you need to be using your own cells, not somebody else's. You need to be processing them and re-injecting them the same day. You cannot save them to use months or years later. And number 3, they need to be used for musculoskeletal conditions, not for other things. Another question I often hear is, if I'm older, should I use someone else's cells? It makes sense why people would think that, but the reality is no. The evidence shows that for the vast majority of orthopedic conditions, if you use your own cells, your own living cells, that is what's safe, that's what's effective, you'll still respond well. Is there an age limit? For the vast majority of things that we treat, there is not an age limit. The one exception are hips, where if you're over the age of 65, it can be more difficult to improve. Again, what sort of doctor does these treatments? I talked extensively about what it makes to be a regenerative medicine expert. There's a lot of different things. It's not just a person who's comfortable injecting into a joint. It should be someone who really understands the nuance of this. Another common question, can someone be treated if they've already had surgery? Depends on the surgery. If you've had, let's say, an arthroscopy, surgery, that can still be treated afterwards. In some cases, post-arthroscopy, injecting your own cells would actually give you a better result long-term. If you've had an actual joint replacement, we wouldn't be injecting into that once you've got hardware in there. My general rules for orthopedic surgeries for patients are try to keep your own anatomy, avoid surgeries that are just cutting out tissue and not actually fixing a problem. Always consider a regen med treatment option. If you haven't recommended surgery, see if this is something that is still amenable to non-surgical treatment. Once you do surgery, you're sort of on that path. It's very hard to kind of reverse things that have been cut out. So we're going to talk about some key regenerative medicine topics or concepts. Stability is a big one. So in the world of stability, there is this concept called biotensegrity. Biotensegrity is this concept that if you take a individual units that are weak on their own, if you put them in close approximation and compress them, they're much stronger together. So that is a concept in architecture called tensegrity. In biology, it's called biotensegrity. So prolotherapy is the idea that we inject your own cells or solutions into all the soft tissue structures around the joint that leads to strengthening and stabilizing the joint. You do that from all the different layers of around that joint, and you will get progressive strengthening over time and longer lasting results over time. So as an example, someone comes in with knee pain. Instead of just injecting cells into their joint, you inject not only the joint, you inject the ligament over that, you inject any of the muscles or tendons over that, you inject the myofascial tissue that supports that as well. And if needed, you inject the nerves above and below that if those are pathologic and driving pain. And if needed, you'll even inject into the bone because that supports the cartilage as well. So it's a very sort of 360 or thorough approach to treating things. And what that'll do is give a joint that gets stronger and better longer term. In fact, when I see patients that say that they had minimal result when they've been treated from another provider, the first thing I know to ask is, okay, well, how did they treat you? Were they comprehensive or was it limited in scope? So prolotherapy as a concept means you're strengthening the ligaments and soft tissue structures to optimize a joint functional unit. As a treatment, you may hear of basic prolotherapy. That's where we use dextrose or sugar water. It's the original regenerative medicine treatment. It creates a mild degree of inflammation in the area that we treat, which starts a normal healing process. Then there's advanced version of prolotherapy where we're using your own cells. So in that treatment spectrum, you have different types of regenerative medicine treatments. You've got dextrose prolotherapy, which is relatively mild. In general, people will require monthly treatments for 3 to 6 treatments. For PRP, it's a stronger treatment. We'll talk about that. Moderate level treatment, repeating treatment if needed, will need to be done every 6 to 12 months. Generally, what can be achieved in 3 to 4 prolotherapy treatments can be achieved with 1 PRP treatment. Then there's using your own bone marrow derived stem cells. This is a stronger treatment. You'll get a result anywhere from 2 to 5 years. And generally what takes 2 to 3 PRP treatments can be achieved with 1 bone marrow stem cell treatment. Excuse me. Okay, great. So it's a case study, a 71-year-old man, chronic lower back pain after 2 prior lower back surgeries. Unfortunately, we see that commonly. We ended up treating his back with his own blood platelets, initially platelet-rich plasma in a prolotherapy style, which means we were injecting not only the epidural space where the nerves come out, we treated the ligaments around the spine, the muscles around the spine, and even the facet joints that connect to different levels of the spine. His initial treatment gave him about a 30% degree of pain relief. He wanted to do better. We ended up escalating to using his own bone marrow stem cells, a stronger cell line, same target areas. He's now 75% better and doing even better. What's nice about this case study is understanding that prolotherapy means you're injecting multiple different areas at different levels, the whole functional unit. And number 2, realizing that there's different types of cell-based treatments. So orthobiologics, these are the cells and tissues that we can inject into damaged orthopedic tissue. Again, please use your own cells, not somebody else's. This utilizes a normal healing process. When you use someone else's cells, there's always a potential risk for infection or rejection of that tissue and cells. So if possible, use your own living cells. Platelets are the first line type of orthobiologic. After an injury, as I mentioned, platelets come in, stop the bleeding, release growth factors, stimulate your local stem cells. Utilizing inflammation, that's how your tissue generally starts to repair after an injury. Different types of platelet preparations. There's platelet-rich plasma, where we're taking your blood, concentrating into a high concentration of your own blood platelets. And then there's platelet lysate. Platelet lysate is where we take the growth factors from those same platelets, leave the cell bodies, and then just inject the platelet lysate. We like to use platelet lysate around nerves because it's a little less inflammatory. To do this, we do a blood draw, centrifuge it, concentrate it. There's different types of platelet-rich plasma preps. On the screen, on the picture, you can see the one that's more red and bloody. Tends to be more inflammatory, good for muscles. Try not to use that for joints and tendons. And then there's the amber-colored one, where it has taken out the red blood cells, less inflammatory. The other important thing to keep in mind is that the older or the more significant your issue is, the higher concentration of platelets you want to use. And that's important because a lot of doctors will just do a standard blood draw and then just re-injecting whatever the product is, a small amount. The reality is, if you're older or have more damage, you'll need a higher degree of platelets and thus a higher degree of blood draw than if you have a lower concentration of platelets and a lesser issue. The other thing to keep in mind is that the average amount of blood draw you should have for this is about 60 to 120 cc's. Or in other words, that's about 8 to 16 tubes of blood, sometimes more. If your physician is only drawing out 2 tubes of blood or less, you're not getting a very high concentration of platelets. The only way you can concentrate the platelets and get the same volume is by taking out more blood. And so if your physician is only taking out like 2 or 3 tubes of blood, you're getting a very low quality product, and it's not going to give you the right kind of result. So this is a case study of a man who is, he's a regular guy, but he tends to cycle. He is a cyclist, referred to me by his primary care sports medicine doctor because he had continued pain in his knee despite physical therapy and rest. Ultrasound picture on the right shows the patellar tendon, shows the patella, that's the bright white signal, and shows some little bone spurs in the patella and a little bit of disorganization of the tendon. So in his case, we ended up injecting under ultrasound guidance. The picture on the right shows a long kind of needle. This is obviously a zoomed in picture. It's not actually how big the needle is. And very precisely injecting into the patellar tendon. He had 2 treatments over 4 months and got back to his full activity level. I then saw him 3 months later, at which time he had now injured his other leg, his right hamstring, and again did platelets again and doing very well. What I like about this is, number one, to show how PRP or platelets is great for mild to moderate conditions, and how repeating treatment can be helpful, and how ultrasound is so helpful here. The next type of orthobiologic to understand are stem cells. These are the main cells that drive repair after an injury. Again, in this country, you can only use your own cells, and the reason for that is what's safer. You may hear about other types of cells, stem cells. Understand that bone marrow-derived stem cells are the only legal way you can get stem cells to inject into your musculoskeletal tissue at this time in the United States. You may hear about fat stem cells. You can use adipose or fat for structural support. Let's say somebody has a rotator cuff tear. You want to take the adipose, you want to mix it with your own bone marrow stem cells. That extra structural support helps to keep the cells in that area. You cannot create what's called fat stem cell product. To do that, a pure product, to do that, you need to use an enzyme that breaks down the connective tissue of the adipose and just leaves you with your own stem cells. The FDA has concerns about the safety of that in humans, of the enzyme that you need to break down the fat. And so we are not allowed to use that enzyme in the US. So the only really legal stem cell product that has your own living cells are your own bone marrow derived stem cells. You may hear about things like amniotic and umbilical cord cells. Understand that there are little to no living cells in that. Those cells, it comes from after birth, from after delivery. The umbilical cord or the amniotic sac is then taken. Obviously, the mother has consented to this. It's then taken to a lab. They then have to break it down, gamma radiate it, pulverize it, and make it into a powder, put it into a glass vial. That is what's legally required for it to be shelf stable in the United States. They then ship that off over to the doctor's office. It can sit there for 2 years. The doctor then has to rehydrate it by putting some saline into it and then re-injecting it. That whole process leads to no living cells. That's been checked by multiple different organizations. You may hear about IV stem cells, not in the United States. You may hear about this in other parts of the world. May have some benefit in terms of overall inflammation in the body, but really no proven benefit for orthopedic conditions from like a research study or published research standpoint. So still stick with your own cells as much as possible. I think when it comes to deciding which or if you should get regenerative medicine treatment, I think there's a few things you need to consider. Number one is, what is the severity of your issue? Do you have something that is still amenable to treatment? Certain joints, like the knees, even if you have advanced arthritis, still respond wonderfully to treatment. Other joints, like let's say the hip, if you've got advanced arthritis, are much harder to treat because of that severity. The other thing about severity is if you have, let's say, mild to moderate arthritis in the knee, platelets are probably good enough, PRP. If you've got more advanced arthritis, PRP can still help, but it's a little bit harder. It's a little bit less certain, and it may take a couple treatments. While bone marrow, on the other hand, has a bit more consistency because it's a stronger treatment, and treating a more advanced condition is more likely to work well. And then understand that there's a difference between an initial treatment versus a booster treatment. For example, if you get a bone marrow treatment, you'll get good degree of relief for the first 2 to 5 years, slow progressive improvement. If you start to plateau and you're no longer at your goal, you then do a booster treatment. That booster treatment can be with your own blood platelets, because again, platelets will stimulate your own stem cells. And so which treatment you receive at that moment would depend on what treatment have you had in the past. And then the last part is cost. There's obviously a difference in cost between prolotherapy, PRP, and bone marrow based on the processing and involvement that is required to get a proper product and to do things safely and appropriately. All that is stuff. You should be having this full conversation with your physician when it comes to your own condition. In terms of stem cell treatment outcomes, yes, we can definitely improve pain and function even in advanced cases. On the other hand, can we improve your X-ray or MRI images? If you've got advanced arthritis, cannot make your knee X-ray look like what it was 20 years ago. On the other hand, if you have a tendon tear or ligament tear and it's less than 2 centimeters, we can still get that to look back to normal. I'll show you some images in a moment. If you have swelling in an arthritic joint, we can get that to resolve. If you've got damage in the bone, swelling in the bone called avascular necrosis or bone marrow edema, if it's at an early stage, we can still reverse that. There's this term that some doctors like to use called bone-on-bone arthritis. It's a very non-medical term and kind of a bit embarrassing if your doctor is using that term, because it's not really again, it's not a medical term. It's not what credible doctors use. Arthritis, even if you have advanced arthritis, bone-on-bone arthritis, that can still be treated with regen med, depending on the area. So yes, that's still treatable. Arthritis is a biologic condition, still treatable with orthobiologic treatments. If your range of motion and function is still relatively intact, good outcomes are still very possible. All the time I hear patients will say that their doctor told them that they have bone-on-bone arthritis in the knee. You have them bend their knee and it's like fully normal range of motion. Indicative that there's still a good cartilage interface, right? They're still really not truly bone-on-bone. Caveats to this when it comes to advanced arthritis are if you have advanced hip arthritis, as I mentioned before, much more challenging. And your expectations, if you've got more advanced arthritis, should be based on improving pain and function, not necessarily reversing what your imaging looks like. How about tendon and ligament tears? Can those be treated? It's a nice study. Yes, by the way, I do see questions coming up. I will make sure to answer those in a moment. So if you have a partial tear, definitely we can treat that. If you have a full thickness tear, in some cases we can still treat that. And this is kind of an exciting study to show this. 20-year-old man, he's a butcher. He had an ACL tear playing recreational volleyball. I saw him within a couple of months of treatment, treated him with his own bone marrow stem cells. And in 3 months, doing great, no pain, restarting dynamic activity. His imaging is what's exciting, which I'll show you in a moment. So the images on the right here are of an X-ray or fluoroscopic exam injecting an ACL. That's the needle. This is the knee joint. And what's lighting up here is the ACL. And this is the right way to do this technique. What's exciting about this case is that you look at his MRI images and the changes. The MRI on the left, these are his pre-treatment MRI images. And what you see in the ACL is a lot of haziness. This has been described as likely a full thickness tear by the radiologist. You look at this 3 months later, you now have an ACL that looks perfectly normal in terms of its contour, linearity, no more haziness, right? It looks very clear. You do still have a little bit of fluid, but it's dramatically better than what it was compared to 3 months ago. So an exciting result from not only a pain relief, functional improvement, but an imaging result as well to show how you can actually repair this. It's a nice case of a 57-year-old man who had stem cell treatment for his right shoulder because of a rotator cuff tear. He's been doing overhead activity as a general contractor for decades. What you see on his ultrasound, the 2 pictures on the left, this is the tendon, the rotator cuff, that's the bone. You see this big hole, black hole there, that is a tendon tear. And that's in fact a full thickness tear and slightly retracted. This is a few months after treatment, and now you have a tendon where it's now filled in. functionally doing great, pain doing great, and you have a tendon that looks pretty darn good as well. So the keys are, if you have a tendon or ligament tear, if it's just slightly frayed, it'll look just a little bit distended. If it's partially torn, you'll have a couple of fibers out. If it's fully torn, you'll see like a small cut through the whole thing. If it's fully torn and retracted, then that's where the ends of the ligament or tendon pulled back. If it's fully retracted, then you need surgery to put that back together. I would recommend consider having your surgeon or us put bone marrow cells back into that after surgery. Sometimes it can be hard during surgery, and the reason why is because part of a lot of surgeries, for arthroscopies at least, is that they're doing it needle-based, but they have to keep the area open. And so they're generally using water to kind of keep the area a little bit more distended so they can have a more clear look at the structures. By doing that, if you inject cells at the same time, the problem is that the cells will get washed out. And so in general, if you've had a surgery because of a full thickness tear that they've had to reattach, putting cells in 4 to 6 weeks afterwards is worthwhile considering. Interventional orthopedics. This is the study of, this is the field where we're utilizing image guidance to treat orthopedic injuries. It's a nice picture of a rotator cuff that's being injected. It's the tendon, the white line, the hyper white kind of curved line is the bone, and the straight white line is a needle. Again, this is a zoomed in picture. But where you see the tip of the needle injecting into is a small little hole. This is a 1 by 1 millimeter tear in the tendon. Looks very big on the screen, but in reality, very small. To inject that precisely, you need ultrasound guidance. This is a picture of injecting into the shoulder joint and then also into the labrum. What's cool about this is we confirm that we're in the joint by seeing contrast in the joint. And we know we hit the labrum because that's that little triangular structure there. That's how to do this correctly. I showed these pictures before, but again, an example of utilizing interventional orthopedics, image guidance to inject joints and tendons and ligaments. Picture on the left, patellar tendon being injected. Picture on the right, ACL being injected. Case study of an ankle, avascular necrosis, 41-year-old man, left ankle, osteoarthritis. He's a chef on his feet for 13 hours at a time. He had a little bit of inflammation. You can see that because on the pre-treatment MRI, you see some narrowing of the joint space. You see a little bit of fluid in the joint. And he also has some early stages of avascular necrosis, damage to the bone. That's dangerous to the joint because the joint normally gets its blood supply from the bone. The bone is being actively damaged. The cartilage will not get its blood flow, and progressively this joint will get more and more arthritic. In his case, we utilize his own bone marrow stem cells injected into the joint, the ligaments, and into the bone, right where the bone is inflamed. He's now a few years out. What's exciting is fluid has been diminished significantly, no more fluid in the joint. He also has complete reversal of that avascular necrosis or damage in the bone as well. So we've actually not only treated his pain, his instability, his function, but we've actually helped to preserve his cartilage longer term by treating the bone as well. Regenerative medicine treatments offer safe and effective solutions for your pain. Getting back to some of these questions, someone asking about degenerative disc disease. So this is wear and tear arthritis in the spine, definitely can still be treated. Personally, I will treat lumbar spine. If you need something like the neck treated, I would refer you to a colleague. But absolutely, the keys there are to treat the epidural space where the nerves are, the facet joints between the different levels of the spine, and the ligaments to help strengthen and protect the spine longer term. See someone else for osteoarthritis? Yes, absolutely. Probably the main thing that we're treating with regenerative medicine is osteoarthritis. And again, after we're done today, you can always reach us at chicagoarthritis.com or at any of our social channels if you need to get a hold of us. So is this too good to be true? There's actual data on this. So Philip Hernigue, French orthopedic surgeon, has been doing bone marrow stem cell treatment since the mid-1990s. He actually compares his patients that needed one knee replacement and then he treated bone marrow with the other knee. Or shoulder patients. One patient, same patient needed rotator cuff or surgery on one side and then bone marrow on the other side. And he finds that there's a very similar response. And again, evidence that you can get a similar response without a big open surgery. Regenetics Network has data since 2005, so there's lots of data here now. And the expectations have been very high about what sort of data is legitimate. There's a lot of junk science out there that is not really appropriately studying things. But in general, for the good quality studies, the data looks very good. Look, in terms of experience, I have personal experience since 2008 in this field. The field is rapidly developing, but it's not new. I have colleagues, orthopedic surgery colleagues, who, let's say 10 years ago, were saying they didn't think these treatments worked at all. And now they're saying they're not sure, but it's worthwhile trying. But they're still not even sure what the evidence is. And when you look at the evidence is pretty darn good for a lot of different things in the field of musculoskeletal medicine. There are definitely right ways and wrong ways to do this. Your doctor should be an expert in all this. Your expectations should be grounded in reality and evidence-based medicine, and your doctor should be able to communicate that with you. How long do results last? Again, there's data that goes out 20 plus years now from Dr. Hernigue. Regenetics has over 15 years of data. What I still tell people is, if you have a chronic condition, expect that a repeat treatment at some point in a few years after initial treatment will be needed. So for example, let's say you have a moderate level of arthritis in the knee. You get 1 or 2 PRP treatments. You'll probably do well for the next 2 to 3 years. You may need a repeat treatment after that time. Or let's say you get a bone marrow stem cell treatment for the knee. You'll probably do well for the next 5 years on average. You may need to either repeat the full bone marrow treatment or just do a platelet booster at some point. On the other hand, if you have more advanced arthritis, you may get the bone marrow treatment up front, and you may be getting a platelet booster after 2 years. Depends on the person. For chronic conditions, what I still recommend people think conservatively, expect a repeat treatment at some point, which may be a couple to a few years, will be needed. The best ways to maintain your results long-term: improve your biomechanics. That's with physical therapy and exercising. Use the appropriate joint supplements for inflammation. Repeat treatment is additive to initial treatment. That first treatment, you may get up to this level, maybe you're 65% better, but you want more. You may be at that level longer term, just kind of plateau there. Second treatment, you're now lifting off that higher level. You're not starting back at the bottom, you're lifting at that higher level, and now you're going even higher than that. And then maintain ideal body weight. If you have if you're not an ideal or optimal body weight, you're going to have more stress on the lower back and the legs. In addition, if you're not at that ideal body weight, you're more prone to metabolic problems and inflammation. That partly will also make joint problems worse as well. I believe in a strong enough where we have our own physician-assisted weight loss program to help our patients with musculoskeletal issues that need a little bit of assistance on the weight loss end as well. We talked earlier about what makes a regenerative medicine expert. There's a lot, right? All this is required. And if your physician does not have this, then you're not getting the right treatment. A little bit about how we work here at Chicago Arthritis and Regenerative Medicine. Our approach is we're focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Start with a thorough evaluation looking for inflammation, instability, asymmetry, neuromuscular issues. Should always first try to correct with low-risk interventions, exercises, supplements, activity modification if it's not working. And if you're an appropriate candidate, then you consider regenerative medicine treatment. We'll utilize the best quality treatments that come from your own body, always. A plan that is specifically tailored to your condition and needs based on what we know works and doesn't work. And delivering cells using the highest level of image guidance between ultrasound and X-ray guidance. And briefly, if interested in getting evaluated, you can either go to the website, chicagoarthritis.com. You can email us at admin@chicagoarthritis.com. You can meet us on any of our social sites, call us, any of those things. We are available to help. And if you have any questions afterwards, we are available as well. Let's see a couple more questions. Can you help with rheumatoid arthritis diagnosis? Look, yeah, I am a board certified rheumatologist as well. And, the thing is, if you have an inflammatory arthritis, like rheumatoid arthritis, if your total body is inflamed, the evidence for how well some of these, the available medications that have been around for over 20 years for rheumatoid arthritis is pretty overwhelming. You should really get treated with that first and foremost. If you're still having some residual problems from one or two inflamed joints, or you're still having some residual problems from wear and tear arthritis, which is more common in rheumatoid arthritis as well, then consider a regen med treatment. Makes a ton of sense. Okay, good. All right. Well, we are coming to an end of our time today. Thank you. Got your message regarding upcoming appointment. Look forward to seeing you then. Whatever test results you've had done, just send that to us. We'll take a look at it and try to give you a good opinion. And look, if we can help out with anything else, please let us know. And if you have any other questions or want to meet up for a consultation, let us know. And until we connect again, I hope everyone stays safe, stays healthy, and live well. Bye-bye.